Thank you very much, Dr. Peter Tawil. I'm so honored and very happy to meet with colleagues across the webinar. And the topic, as mentioned today, is about CBCT as a helpful tool for treating in endodontics, for developing a treatment plan, and for diagnosis and for demonstration for your patient. So, it is well known and recognized that radiography and endodontics, they go hand in hand, and radiography has substantially developed the endodontics in the diagnosis for examination as an essential tool, and commonly the X-ray, commonly in dental practice, is a combination most of the time between the periapical X-ray and the panoramic radiographs. However, those two kinds of radiography have limitations. Limitations because they are an image in 2 dimensions. And this limitation will omit the 3rd dimension, which is very important for us as to evaluate the case, the situation, and to develop the treatment plan. In a paper or a book published in 2016 by Dr. Fayyad and Johnson, they mentioned that the interest of the CBCT in diagnosis. And through this page, you can see that examiners, 3 examiners, have appreciated the CBCT and evaluated the situation where 3 examiners changed their treatment plan after observing the CBCT, and this would confirm that more than 50% of the cases, your treatment plan might be affected by this kind of 3D dimension. So CBCT in Endo will help you develop an accurate diagnosis, will help you elaborate a treatment plan, and would guide you on a step-by-step procedure how to conduct it. And beside, for us, it is a valuable presentation for the patient where instead of using an extracted tooth or a dummy that you have purchased, or even a model that you would have downloaded from the website, any tooth, that will be a personalized on the patient's tooth, a personalized treatment plan, and a preview for what's going to happen during the procedure. Well, I'd like to mention that I have no financial interest in that lecture today, and I'd like to introduce to you one of a specific softwares that I have on my own. And this software is very helpful for diagnosis and treatment planning in Endo. That was developed by Dentsply Sirona. And you could see from the picture that it has really 3 specific points that are very interesting for us. It has a metallic artifact reduction software, and it has a smaller field of view, 5.5, and it deals with pictures that are smaller than 0.2 millimeters for definition and precision. Well, from the CBCT, we will look for criteria to evaluate. We will look for example, the extent of the lesion and the bone loss, the presence and the extent of external resorption when they exist, and whether it is better to deal with the case non-surgical first and then surgical procedure, and you can even conduct the surgical procedure with all the means through that software. With the case series that we will present today, there will be 3 of them, we will be able to appreciate the benefits of the CBCT. Let's start with the first case. This young female of 22 years, she was referred for retreatment in preparation for surgery because of this extended lesion. The referring doctor accessed the tooth for drainage, and he mentioned that he found a citrine liquid flowing out of the tooth. So he programmed the patient for surgery. And the patient was referred for a second opinion. Well, you can appreciate here the extent of the lesion going from the mesial to the central and to the canine with an extended lesion that you see in the circle. Well, we would be able on a CBCT to appreciate the bone loss. And as you can see, we can move the tooth in all directions and we can appreciate the bone loss, the extent of the bone loss, and the affection of the bone loss on both sides, the buccal and the palatal plate of the hard bone. And this is another axial cut where you can appreciate the extent of the lesion to both mesial and distal sides and the bone loss on both sides of the hard bone. And as you see in the picture, you can also preview the working length, you can preview the depth of the access cavity, and you can even preview the working length of the tooth. And that precision is very accurate. It goes up to tenth of a millimeters. As well as you can preview your instrument with which you're going to shape your canal and your final instrument, because you'll be able to decide or to determine the apical diameter of that root with some kind of precision. And that's how you can preview the progression of the treatment, the length, the final instrument in place, in position, and as we mentioned, the final diameter of the preparation. So here is a conventional X-ray that was with the PA that was post-operative in 6 months after filling the root canal with MTA at the apex and continuing with the filling coronally with a gutta-perca. That was 6 months, and you see that you can notice the difference in bone density and how it evolved. And this is 9 months post-op. And we could now decide which is the adequate treatment plan. From a surgical procedure, we stepped into a conventional one, a conservative one, with no blades, just doing the root canal from the inside, a conventional non-surgical root canal therapy, and it ended with a smaller lesion. And we'll be following the situation with time. And I'm sure, almost sure, that it will be a complete healing. If not, a residual lesion will be persisting, but I'm sure that will be a very big advantage for the patient. Well, another clinical case would be about the presence of an MB2, the mesiobuccal 2 canal, in the mesial root of upper molars. Well, it is well known that it exists in almost 100% of the cases. And this is a publication by Dr. Parker and colleagues in the Journal of International Endodontic Journal in 2016, where it was mentioned that the CBCT used in clinical endodontics would affect positively the research and finding of the MB2 before your procedure. So this is a clinical case where the patient was referred for us for a second opinion. Through the X-ray, you would see that there was a destructive access cavity looking for that MB2, and even the MB1 could not be adequately treated. The doctor mentioned to the patient that he would prefer, because of an infection that he could not control, to do a resection or a retrograde surgery, or even extract the tooth and place an implant. Well, we would see that with the CBCT, we were able to change that treatment plan and be very conservative with a non-surgical root canal therapy. Well, here is the preoperative X-ray, 2 preoperative X-ray to evaluate, but it was not enough for us. On the CBCT, we were there to isolate the tooth and analyze the situation with much more precision. So you could see the lesion, the extent of the lesion. We would isolate the tooth, and this is specifically the tooth isolated, and you could see on the CBCT the presence of an MB2 on the X-ray. So we would continue with the program. That software is able to determine for us, if we are looking for the MB2, the length of the MB2, the entry of the MB2, and the depth of the access cavity, and to what extent or at which level we can be finding or looking for the MB2 with precision. Of course, the microscope is very helpful to conduct that procedure and would be really very rewarding for the final result. As mentioned before, with the software, we can preview the working length with precision. As I said before, we can preview the final diameter, we can select the final instrument, the master apical file, and as you see here, this is the PA during the procedure with both canals where we have to retreated the MB1, we have found the MB2, and this is the final X-ray with all the canals retreated almost perfectly well. This is a third case presentation where the patient was referred to me because they wanted to see if we can do a re-surgery for that patient. And you can notice from the bottom photo that a previous surgery was done and it was conducted by a dentist. However, that was not a real success. And you would be able to see on the X-ray that 4 of the teeth were done surgically, were treated surgically. On the PA, there is a kind of transparency, but on the panoramic, you could see that there is a lesion of endodontic origin on this central incisor. That tooth was causing pain for the patient. And the patient, because of her moderate situation, financial situation, I mean, she would be preferring to treat only that tooth which was causing pain, and not really going into the treatment of the whole segment. Well, let's go and see what the CBCT would be in our advantage. So I can, with the CBCT, isolate the tooth. I can analyze the extent of the bone loss, as I mentioned before, mesially, distally, and on the both of palate of hard bone on the buccal and the palatal side. So I can move my cursor in all directions, and then I can rotate the tooth. I can in both directions. I can even tilt the tooth to see the entry of the canal. And that's not a dummy, okay? That's the patient's tooth. How does it affect the treatment plan? I know that I'm going to do it surgically, but I know the extent of the bone loss, which is coronal here. There is a residual part of the bone down in the apical area. To preview guided bone regeneration, in case you have a complete loss of the buccal plate, or in such a case, I can limit my surgery just to a retrograde surgery on the apical part and a retrograde filling. So this is how the surgery was conducted. I reflected the flap, discovered that all I've seen on the CBCT was there. I could prepare a retrograde cavity, 3 millimeters depth, fill the root canal, and that was the final X-ray right after the surgery. So here is the third case where the patient is a female of 16 years. She had a history of trauma at the age of 8, and MTA were used for this patient for apical closure. You can see that there is a discoloration because maybe of the MTA that was placed, discoloration of the crown. An orthodontic treatment was followed, and the patient was referred for that dark tooth and for bleaching, a kind of bleaching of the tooth to reestablish the look for the patient. In fact, I wanted to explore the situation more and more, and I asked for a CBCT to explore the whole process, because on the PA, I could see that there was a kind of lesion. There is a big extrusion of the MTA outside of the canal, and I noticed also that there was a kind of perforation or resorption in the coronal aspect of the tooth to the mesial. So that was maybe an introduction to modify the treatment plan because I was suspecting an internal resorption. So what to do, where to do, how to do, that will be the purpose of the CBCT. And according to Hezersay classification, we could, from the CBCT, find out on which situation we are, whether it is a primary class 1 with a minor resorption or an extended resorption, the third class with an extended cervical area, or well, the whole tooth is damaged, the whole root is damaged from the class 4. So on the CBCT here, we could see on the axial cut the extent of the resorption. It extended lingually and mesially. And this is second view going from the coronal down to the apex. And you could see the lesion extending into the root, deeper and deeper, deeper and deeper in all its dimensions. We could also isolate the tooth as we did before and appreciate the bone loss and at the same time the extent of the resorption. So moving the cursor again, we can move the tooth, and here you start to see on the mesial aspect the exact location of the resorption and the extent of that resorption. So dealing with it is very challenging, and you can see that the complete cortical bone loss is here in that situation. So here it is. On the CBCT, I could determine the working length. I knew that I have to remove all the MTA from inside and from the outside, do it again, removing the extrusion of the MTA, closing the perforation due to the internal resorption, and hope for better prognosis for the tooth. So this is the axis and the depth cavity. And in reality, when I removed the temporary dressing, I could see clinically under the microscope the location of the resorption and the extent of the resorption, right exactly as I saw it on the CBCT. So this is the preoperative when after isolation with the rubber dam, and this is the complete filling of the resorption with the MTA. So at the same situation, at the same session, I could close the gap with the MTA, fill that internal resorption, and conducted my surgery as I saw it on the CBCT. So a reflection of a flap, removal of the excess extruded material of the MTA, closure with two small sutures, and here is the final X-ray, the day 0. And you could see that the MTA excess was removed, and observe here mesially how I could close without any excessive material pushed out in the interdental space. It completely cured the situation. And here is the post-operative X-ray 6 months later. I know that from a restorative point of view, it's not the best crown, but you could see that there is a healing in the apical part, and the thing, the lesion or the situation is going into the right direction. So what are the benefits of the CBCT? And just to mention a citation from the American Association of Endodontists, many cases the CBCT could help in diagnosing extremely difficult case where we had a vertical fracture, for example, resorption, extent of the resorption, to preview the surgery. And we could conclude that as a take-home message, that the benefits of the CBCT are growing steadily. Those potential benefits should outweigh the potential risk on the CBCT. Of course, you would not do a CBCT for a simple case, but let us find where is the simple case. We would finally recommend that the CBCT is prescribed, and keeping in mind that the ELERA law must be respected. So thank you very much for your attention and hope to see you again.